Welcome to The Whole Pineapple. I'm Ruby Booras.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. And on these weekly mini episodes, we bring you bite-sized ideas for you to snack on.
Like breathing exercises, book reviews. Maybe we'll review some scientific research, or we'll share some wellness and fertility stories from our listeners.
So if you're looking for a tip or a trick related to your fertility and well-being, then you've come to the right place.
Let's dig in.
We are so pleased to welcome back to The Whole Pineapple Dr. Paul Lin. Hopefully you got to listen to his full episode where we kind of did a rapid tour through the uterus and all the things that can sometimes be challenging. But today we're happy to have him back to talk in more detail about fibroids. We didn't go into it much in the full episode because we know it's such a common condition and we really wanted to be able to make it a little bit more bite-sized and palatable, even though fibroids are often not bite-sized. So welcome back, Dr. Lin.
Thank you for having me again. I guess I was not so, the first episode was fine.
Yeah, see, it's fun. We meant to even ask you about your OR playlist because I know that's often a source of common conversation.
Is that coming up again? Is that infamous?
It's infamous for sure.
My dance parties during my egg retrievals? Yeah. Everyone wants to join.
Yeah,
You're welcome to come in. Wake up early at 6 a.m.
Oh, no.
No one's going to take that one. I like to have music in my, it helps relax me. When I was always studying and stuff, I always like to have music in the background, just kind of helps settle the mind. And it's the same thing when I operate. It just helps me concentrate.
Well, especially for something that requires so much hand-eye coordination for delicate surgeries, like I feel like you've got to have something to kind of like settle yourself. So do you always listen to the same thing or is it just whatever you're in the mood for?
No, it's a variety. That's why it's always a crapshoot. You never know what you're going to get. You could get 70s, 80s. The only thing I don't want is country, but that's okay. I'll have a little bit of country. It's okay. Some of my staff like to have country. It's gone. But I won't have rap. I won't have rap. That's my only one that I won't have. But everything else is up for grabs. I like all kinds of music.
Well, eclectic, just like all the surgeries you do.
And just like the fibroids, they come in all different shapes and sizes
and placements
and places. And
do.
So, you covered briefly, I think, a great explanation in the main episode about the difference between polyps and fibroids in terms of where they originate. So, fibroids, as you mentioned, they're coming essentially from that muscle layer of the uterus, which is like the power horse of the uterus. I mean, that's what it does. When you were talking about the size of the uterus as a pear, I still remember that crazy moment. And Ruby, you probably had it postpartum too, where you just like look down and you're like, oh my gosh, you still look pregnant, obviously right away, but you look so much less pregnant. And you're like, that process of your uterus being able to stretch to accommodate a pregnancy and then just shrink on back down, let alone the hard work involved in labor. I mean, the uterus is really just a truly amazing muscular organ.
It's pretty impressive, especially when you have 2 10-pound bowling balls and you're like, wow, way to go, uterus.
Yeah. It's one of the few organs in the woman's body that changes so dramatically back to its normal size, back to pregnant state, and then back down to its normal size. How many organs can you think of that does that? I can't think of any.
And it's so hopeful.
Yeah. And the enigma is the fibroids. They're influenced by many different things. The causes are largely unknown. There is a genetic predisposition. Unfortunately, African Americans are at a higher rate of fibroid development, and we don't know why. So we think there's a lot of different causes. As anything, it's probably genetic. There's probably a genetic marker that's a mutation or non-mutation that occurs that predisposes that woman to developing fibroids. I've seen fibroids in all ethnicities of all sizes. So it's actually very common, affects probably about 5 to 10% of the women out there, which is a large proportion of women when you really think about it. And it affects about 20 to 25% of women who are struggling to get pregnant. So we do see a lot of fibroids in this population.
And do you see differences in different countries? I mean, across the world, does everybody deal with fibroids? Do they think that there's some sort of environmental influences or any reason or is it really kind of about the same?
There are lots of looks and sees at whether there's environmental things, but no, there has not been a distinguishable pattern other than the African American association. It's totally random. And it's totally random as to whether or not they're going to be significant for that woman, too, in regards to symptomatology and the effect that it has on getting pregnant. But I think when women are struggling to get pregnant, I always use the analogy of location with fibroids. It's not whether they're there or not, it's where they're located within the uterus and relative to where the baby grows when it comes down to whether or not it's going to affect a woman's ability to get pregnant.
Well, yeah, Ruby, you mentioned having a 10-pound baby. You know, we had a patient here not too long ago that came in trying to have her second child, and we discovered kind of incidentally she had this over 10-centimeter fibroid that she had with her first pregnancy as well. They noticed it in pregnancy, and it didn't really cause her a lot of issues. And it was this whole discussion about, well, gosh, it looks so big, like it looks so prominent on ultrasound, but like, should we think about removing because it didn't cause her any problems in the past? She wasn't really having any pain or symptoms now, but it is hard when you're doing an ultrasound and you feel like it's hard to even see the inside of the uterus because all you see at first is fibroid. So where is the location that you're most concerned about versus least concerned about when you find someone has a fibroid?
Well, it's inside the uterus. It's close to that cavity, that critical cavity where that baby grows. So submucosal fibroids that are inside the uterus rather than outside the uterus where it's on the on the surface. You know, when we talked about bunny rabbits, there's literally those fibroids are not significant when they're literally Mickey Mousing the uterus. So we tend to leave those alone unless there's pressure effects. So I'm amazed with that 10-centimeter example that you had, that woman did not have any symptoms of pressure.
And once we talked about it, some of it was, I think she just like, well, I thought it was kind of normal, especially after having the baby, that I always feel a little bit of bladder pressure or this and that. And she didn't know that it was related to maybe that big fibroid sitting right there.
Right. And it probably was. And so that causes constant. You have to think about the collateral events that women commonly compensate for, right? They have constipation, they have obstipation, they struggle to move their bowels and stuff, and they go to the bathroom frequently. So you start eliciting how many times you go to the bathroom? Well, I go 20 times. And that's actually pretty excessive. Normally, a woman should go maybe 6, 8, 9 times. And then urgency, right? And inability to when they get that urge and they're driving a long distance, can they wait? How long can they wait? Or do they really need to go? These are the very common symptoms that a lot of women submarine those symptoms because they just don't want to deal with that type of stuff. Again, it's the history taking that you kind of bring perspective to that woman in finding out whether that fibroid that they have or known that they have is actually significant. Then you start doing the imaging, right? It's all about imaging, the ultrasound, the uterine evaluation. I don't think you need to do an MRI right off the bat, but an MRI is part of the evaluation, especially when you're thinking about surgery. And you're seeing the location of that fibroid relative to where the baby grows. And the closer and the larger that fibroid is to that endometrial cavity, the more significant it has on that woman's ability to get pregnant. So if a submucosal fibroid is basically defined as literally inside. So if you do that office hysteroscopy that you guys described, and you see the fibroid, no matter how big it is, that's going to have an impact on that woman's ability to get pregnant. So this is where size doesn't matter. It's the location. If it's small, if it's large, it's going to have this rubbing effect. People often think that fibroids impact the ability of that fertilized egg to implant. Not only does it do that, but it also causes collateral damage. So it's rubbing up against the opposite side of the
inflammation.
Yeah, and it's causing that inflammation, right? And that rubbing.
That's also kind of why I love office hysteroscopy. I know it can be a little bit of a crampy test, but you get to see it. I think there's a big benefit when you're actually lying there and you're like, oh my gosh, I could definitely see how that whole bottom part of my uterus, that's definitely that big bulgy thing there is not something that I can imagine an embryo being able to burrow into. And then as you mentioned, if you're doing the opposite side too, you're leaving a real small area. So
yeah, pictures speak 1,000 words.
Yeah. That on office hysteroscopy, your uterus kind of looks like a cave.
It's the Cave of Wonders, like on Aladdin. A Disney person. Okay. So you have your cave, yes?
So got the cave, and the fibroids can be like a boulder, and it can really distort the cavity sometimes. And of course, they can be of different sizes, so they can be more significant. But And sometimes you can get fibroids that aren't necessarily on or in the inside of the uterus, but can distort the uterus by pushing on it because it's so big, because it's in the muscle of the uterus, right?
Yes. When you're pregnant, oftentimes people worry about pregnancy. It can cause dystocia or an abnormal labor, right? Because the uterus can't contract correctly around that fibroid. So you get abnormal labor patterns. You don't dilate as well during labor. So that's a collateral. And then it can cause preterm labor, which then as a result can cause preterm delivery, which can have an impact. So a lot of women, I counsel about the impact of those things happening, but it's not necessarily a reason why I would operate. I just warn them about that. If they've had no history of it, if they see a fibroid and it's causing no symptoms, but they're worried about their future pregnancy, I don't necessarily jump on the surgical bandwagon at that point. I say, well, it could have these impacts. And if it's really causing a lot of anxiety for you, then yeah, go ahead and proceed forward with the surgery. But the main reasons that I talk about surgery and doing surgery is the location and the symptoms. Again, going back to the endometriosis discussion, is the symptoms that you're having significant enough to affect your quality of life? It's always affecting that quality of life, right? In terms of heavy periods, in terms of irregular periods, those type of things. Are you clotting? Are you soaking through multiple tampons? Are you soaking through multiple pads? Do you go to meetings and you get embarrassed because you think there's going to be an accident? These are significant things that most women kind of try to submarine, but I bring that up to a head that you don't really need to deal with that. No woman should deal with that. And so that's where the role of surgery comes into play, and I start talking about it.
But people can have fibroids with no symptoms, right? That's one of the challenges.
That's correct. Yeah. Just because it's there doesn't mean you have to remove it. So I oftentimes have that conversation. A good surgeon knows when not to operate too.
Mm-hmm. Sometimes it's the most important thing. And, I think also because many more just primary or OBGYN practices, I think are doing a lot more ultrasound than they used to, which is great. But I'll have patients come in, even just for egg freezing, and they're really worried because someone's also told them they have a fibroid. And we're doing an ultrasound to look mostly at the ovaries, but we see, yeah, you've got a little, just only in the muscle. It's interesting how I think, obviously we see more. That's why some hospitals would offer like full body scans. Like you don't necessarily need to know everything that might be a little bit unique to your body because it may or may not cause you any future issues. So yeah, focusing on the location and the size, and especially if you're having symptoms, those are the key things that say whether we need to actually do anything about a fibroid. And fibroids, of course, just like we talked a little about with polyps, anything in the uterus, people worry about cancer. So what do you say when someone's concerned about being told they have a fibroid and knowing whether that's something that might be significant for being something that's cancerous?
Especially when they get their records or they get their explanation of benefits in the mail and it says tumor, uterine tumor on it. Yeah. That freaks people out.
I hate the word tumor, but it's a word.
It's not a tumor. Sorry, Arnold Schwarzenegger.
We are full of the 90s references on movies now.
It's not a tumor. We just talk about being benign. I use that word a lot. Yes, could it be something that is malignant? I guess as a physician, as providers, we always have to tell our patients that it could be this, it could be that. But as someone who likes to look at things glass half full, I tell them the statistics that it's probably 1 in 300, up to 1 in 4,000 chance that this could be a leiomyosarcoma, which would be rapidly growing type thing. And if you've had this if it was first discovered 3, 4, 5 years ago, and now it's maybe double the size, that's not a tumor. That's not behaving like a tumor at all. So I try to do a reassurance on that. But I also tell them that if you're thinking of doing surgery, if you're really worried about it being cancer, right? I hate the C word, but we mention it, then we should probably remove it because, again, it's about quality of life, and mental health is about quality of life. So if you're completely anxious that this something could be cancer, then removing it makes sense. And then we do send it off to the pathologist, and that's a certainty there, is making sure that it's not cancer for you. So I have that discussion as well.
And the way you remove fibroid is also very based on location and size. So maybe talk a little bit more about the different approaches to surgery.
So it can be done with a hysteroscopy if it's a submucosal fibroid. If it's completely inside the endometrial cavity, there's a size criteria. You don't want to go above 3-4 centimeters because it's just simply too large. You can't see around it. Oftentimes when people are very insistent on doing it hysteroscopically because there's no incisions necessary, I taught them about a stage approach. Maybe I'm going to get some of it, but I'm not going to get all of it. I will try to get all of it, but with a fibroid that size, sometimes you have to deal with a complication called fluid overload. We have to distend the uterus with this fluid, and you can get absorbed very quickly. And if you get too much of it, you can have complications from that. So we have to cease the procedure. So I always talk to them about that. So that's actually the more straightforward procedure. It's a day procedure. You come in that day, get it done. An hour later, you wake up and you recover in the recovery area and leave the facility pretty quickly, and no incisions are made. It's all going to your natural anatomy. With the second approach, laparoscopically, if they're larger or they're more on the outside or muscle portion, we do laparoscopic surgery where small pokes are made in your belly. I do it with robotic platform if the patient is insistent on that, but it's not required. I can do it with either. And that's another minimally invasive surgery where you come in that day, but it does take longer. It takes, instead of an hour, it probably takes me about 2-3 hours, but who cares? You're out, right? You're in Hawaii, just dreaming the life. And with those type of surgeries where the incision is made into the outside of the uterus, we talk about C-section being likely because I'm making an incision and I'm removing that fibroid. I'm creating a huge defect, and I have to put the uterus back together, good enough to obviously carry a pregnancy. But when you labor, the contractions, that area serves as a weak point. And when you're laboring, that area being a weak point can rupture. And that could be detrimental to both baby and mom. So we often talk about a C-section happening with that.
So you can have a laparoscopic surgery where you might just have those little poke holes and you don't have what you think of as like a C-section scar on the outside of the skin. Right. But because you've cut the uterus, that's why you have that concern. Because I think people do get confused about that. Like, but I didn't have a C-section. I don't see any sutures on my abdomen. So
yeah, and that's a good point. So it's small incisions. And then, of course, if they're super massive or they're going above the belly button and you can't literally see it all, then we do have to sometimes do a big incision, a C-section type incision or an up and down incision in order to remove a fibroid of that magnitude.
What's the biggest fibroid you've ever removed?
Well, I was up to her xiphoid.
Oh my god!
Oh wow!
So up to the heart. I think it was like 4,500 milligrams, so 4.5 kilos.
Can you imagine walking around with that? Like someone just giving you that amount of weight to be carrying?
Poor girl she was a very thin woman. Everyone thought she was pregnant. The poor girl just could not deal with that, and so we had to remove it. But it went back down to normal size. It was on the outside of the uterus, and she's happy as a clam.
What are the recovery times like between the different surgeries?
So hysteroscopy in terms of getting pregnant. So hysteroscopy, like I said, is an hour recovery out of the hospital. You're probably out of work for maybe a day or two, and getting back to getting pregnant, probably a month or so, really quickly. With laparoscopy, if it's involved that much, it's 3 to 6 months before you can try to get pregnant. 1 or 2 weeks of just being out of a desk type job. So it is a longer time frame when you're making an incision into the uterus. But with the minimally invasive approach, I oftentimes have women overdo it because they look at their incisions and they're like, wow, I can conquer the world. And they start running and then they realize they can't do that. And so aesthetically, it's very nice, but there's still a lot of healing because what happens is the uterus has to inflate, has to shrink. The uterus has grown around the fibroid over the many years that woman has had it. And after I remove that fibroid, it's still large. So it has to shrink and involute and go back down to its pear-like shape. And that takes 3 to 6 months.
Yeah, I know. I'm sure, Ruby, you have the same story of like sometimes an HSG on someone like where you just feel like you're just using so much contrast and you're still just barely filling
Can't even get to the tubes.
Yeah, you can't even get it to go in the tubes. I mean, it's pretty impressive what the uterus is capable of stretching and then but as you said, recovering as well.
But it's a very tolerable procedure if it's done hysteroscopically, laparoscopically, very minimal impact.
What's your rate of fibroids recurring? So when someone removes them, is there a time frame that you think you kind of have a window before they're likely to come back? Is it likely that they won't come back? What do you tell people?
Well, I mean, statistically, they're likely to come back, but they're likely not to come back significantly. That's how I usually word it. Okay. So if there's a fibroid there and you do another ultrasound in like 3-4 years, there's going to be a fibroid there most likely. But is it going to be significant? Probably not. In regards to symptomatology, in regards to their ability to get pregnant, I don't, as a standard, recommend, annual doing ultrasounds I get that a lot. Like, should I just watch these? And I'm like, only if you're symptomatic. If you start developing the symptoms, you're very familiar with how we got to do the first surgery. If you start having those symptoms, let's do an ultrasound. And I've done a few of those. And what's been the most likely outcome? There's a small fibroid there, but it's not a big deal. And they're super relieved that I recommend, let's just leave that alone. Probably on one hand, I've had to reoperate on a patient because the fibroid has just come back. There are just women who are susceptible to, rapid regrowth of that fibroid. And there's really no rhyme or reason regarding who that person is. You just have to rely on the symptoms.
Well, I think that was a pretty good rundown of fibroids, and it's a very common thing that we run into here, and I think it'll really help people understand the surgical approaches and what the implications are for fertility and just general life. So thank you so much for being with us again.
Definitely. I keep thinking about our episode with Laura on LGBTQI family building, where she just talks about being prepared, not scared. I'm like, that fits with all these things. Like, you can be prepared, not scared for what's going on in your uterus as well, too. And I think this has been so helpful. And thank you again for your time.
Thank you, guys. It's such a pleasure being here and educating our patient population. I've learned so many anecdotes that I'm going to use on future counseling visits.
Oh, no.
Got to give you credit.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review the Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.